we're going to go ahead and get started. I'll start my introduction. I am Darlene. I am the National Digital Sales Director. I am a podcast host, and I also do some speaking at some of our seminars, and I do that all with SeniorLivingGuide.com. I absolutely love my job, but I also love the company that I work for. And I'm not saying that because our general manager's on here. It's actually just the truth. One of the things that we provide here at SeniorLivingGuide.com is our actual online guests or online users the ability to connect directly with any community that they're looking for, any home care community or resources that they're looking for anywhere in the United States. They're able to connect directly with them. And it also provides our advertisers the ability to have that connection directly with our online users or their potential customer. So that's really what we do on the online side. We also have our SeniorLivingGuide.com podcast, which is a senior and caregiver resource podcast. We just launched our 60th episode, and it can be found anywhere you listen to podcasts. It's a great opportunity to take a listen and share with family, a caregiver, or a senior that you think might benefit from our podcasts. They're available anywhere you listen to podcasts, such as Apple or Spotify. We also have print publications in Florida, North Carolina, South Carolina, or Virginia. So if you're interested in any of those, we have an ebook online, but you can also get a hard copy if you're interested. So once you get my email, let me know. I'll be happy to get one of those out to you. And then we have hospital directories, and I think probably over 45 markets throughout the US. And so that's a great opportunity for some of our advertisers as well. So we really do offer a lot to both the senior and their family, and then also to our advertisers as well, because we really like to partner with them and give them the most bang for their buck. So that's a little bit about me, and I'm going to let Amanda introduce herself.
Thank you. My name is Amanda Marker. I am the Director of Business Development for Windmoor Healthcare. I'm also a licensed mental health counselor. I've been working in behavioral health for over 14 years. Most of my time has been spent working in acute crisis care at inpatient and outpatient settings in mental health and substance use specialties.
Thank you so much. Well, we're super excited to have you. And as we were chatting just a little bit before everyone jumped on, I'm really glad that we're able to have this webinar today, because you and I have talked a little bit about seniors, and that a lot of times people just think that seniors that are sad or depressed or in not a good state, that's just a normal part of aging. And we're going to talk today, as one of our subjects is that's not, and how to recognize that.
Absolutely.
Perfect. All right, well, let's get started.
All right. Well, thank you. Thank you so much for everyone who is taking the time to attend today. I really appreciate it. This is something I'm very passionate about, very interested in, and wanting to make sure that we change the tide on the current trends. So this is mental health and well-being for older adults. We'll review mental health trends, risk factors, unique needs, and tips for improving well-being. From a clinical perspective, we know that good, stable mental health is a major factor in outlook and overall well-being for all people. And most older adults are experiencing the life satisfaction, social, emotional support, and good mental health that are really essential to aging. However, untreated mental health disorders can lead to diminished functioning, substance use, poor quality of life, and increased mortality. So to get you guys started thinking, I want you to think, and maybe put this in the chat box, and Darlene, if you can maybe read it out, what % of older adults experiencing depression have their first episode later in life?
I've got 67, 40, 15, 47.
Yeah, pretty close.
They got a wide range.
Yeah, more than 50% of older adults experience their first depressive episode later in life. So it's not something that you have had to have had experience with, throughout your lifetime. Late onset is certainly something that can happen and is, as we see, fairly common. So we'll go into a little bit of the background. So by 2030, the number of US adults age 65 and older will be more than double to what it is now, about 71 million. And that is so close, right? Just a little over 7 years away, less than 7 years away.
Mhm.
And in 2035, older adults are expected to outnumber children for the first time in US history. Keeping in mind the rapidly increasing number of older Americans has far-reaching implications for our nation's public health system, and it will place an unprecedented demand on the provision of healthcare and age-related services to what we currently have. So a little bit more background, close to 20% of people aged 55 and older experience some type of mental health concern. Most commonly is reported anxiety and mood disorders, which includes depression and bipolar. And one of the things you're going to hear me repeat quite frequently through this entire presentation is that these mental health diagnoses are not a normal part of aging. Although they are common, it is not normal. The Substance Abuse and Mental Health Services Administration, SAMHSA, the National Academy of Medicine, found that 50% of older adults with mental health or substance use disorders are receiving treatment. So less than half who have qualifying criteria for a mental health or substance use disorder are currently receiving treatment. So when we talk a little bit about anxiety, we're going to go over a couple of the common ones, the anxiety and depression. So anxiety can worsen an older adult's physical health. It can decrease their ability to perform daily activities, decrease feelings of well-being. So right now, late life anxiety is not well understood, but it is believed to be as common in older adults as in younger age groups. And anxiety in this age group may be underestimated because a lot of older adults are less likely to report psychiatric symptoms and more likely to emphasize physical complaints when they're with their primary care or other practitioners. So anxiety, it's often characterized by chronic and exaggerated worry that interferes with activities of daily living, lasting at least 6 months. Physical symptoms can include fatigue, shaking, muscle tension, headaches, nausea, and digestion issues. Some risk factors when it comes to anxiety in older adults. A lot of older adults have chronic medical conditions on top of having a potentially new emerging mental health condition. Overall feelings of poor health, sleep disturbances, side effects from medications, and we're going to go into these a little bit deeper later. Alcohol or prescription misuse or abuse, physical limitations, stressful life events, and negative or difficult events in childhood can all affect and play as risk factors for an older adult developing anxiety. Mood disorders, another common diagnosis that we see in our older adult population. This is persistent sadness, withdrawal from previously enjoyed activities, difficulty sleeping, physical discomforts, restlessness, decreased energy, and fatigue. And so although the rate of older adults with depressive symptoms tends to increase with age, again, depression is not a normal part of growing older. So it's important because some of us might consider decreased energy, physical discomforts, difficulty sleeping, a normal part of maybe aging, a normal part of having an older body. However, it's really important to not brush aside these symptoms if you're experiencing them because they can be symptoms of something more serious that needs to be taken care of. Depression is one of the most successfully treated illnesses. There are highly effective treatments for depression late in life, and most older adults with depression can improve dramatically from treatment. So someone who is depressed typically, again, has that feeling of sadness or that anxiety, and it's for weeks at a time. Unfortunately, depressive disorders are a widely unrecognized condition and are often undertreated or not treated at all among our older adult population. Risk factors for depression are very similar to some risk factors for anxiety: poor physical health, social isolation, increasing pre-existing conditions that may make health more fragile, sleep disturbances, increasing use of alcohol or drugs, memory problems, financial trouble, loss of self-sufficiency, loss of that autonomy and needing to ask for help from others. It's a life transition. Lack of access to mental health treatment, and elder abuse. And we know that 80% of older adults have at least one chronic health condition. 50% of older adults have two or more. So depression is common in people who have other illnesses, such as heart disease or cancer, and whose function becomes limited. The good news is that the majority of adults are not depressed. Some estimates of major depression in older populations living in communities range from less than 1% to 5%, but rise to 13.5% in those who require home health care and 11.5% individuals, older adults hospitalized. Again, a question for everybody. When is a first mental health diagnosis made in an older adult?
Go ahead and put that
Yeah.
in the chat box.
And this,
Okay. I have after retirement, which is a good generalized one. And then we have 65, 60, 70.
yeah, so the answer to this really kind of stopped me in my tracks. Many older adults are first diagnosed with a mental health disorder following a suicide attempt.
Oh, wow. Okay.
So let's talk about suicide in older adults. US males 65 and older have a higher rate of suicide than any other age group. Suicide attempts by older adults are more likely to result in death, and older adults are more likely to use lethal means. 70% of older adults who attempt suicide are using a firearm. And so you can see in this graphic here, age 65 and older, 1 in every 4 attempts, an individual will die by suicide. And in all of the other age groups combined, it's 1 for every 20. So those are significant numbers that I think we need to be paying attention to and be mindful of when it comes to how we're addressing the mental health of our older adult population. So older adults tend to plan more carefully. They tend to use more deadly methods. They're less likely to be discovered or rescued, especially if they're living alone and don't have frequent visitors.
Yeah, I don't think people think about seniors committing suicide in general.
Right. It's just not something that I think people talk about, or there's that bias and that stigma or that stereotype of what an older adult is and that normal part of aging. So I found that statistic to be incredibly unsettling. And because many older adults have additional physical concerns, they also may be less likely to recover from a suicide attempt. They may not physically be able to recover from that attempt. And one of the things I think is really important to know as well is that 38% of individuals who attempt suicide, and this is across the spectrum, not just older adults, they saw their primary care the week prior. So I think it's so important for our primary care providers, our mental health providers who are working with older adults to be really mindful of mental health not being a normal, depression not being a normal part of aging. And maybe that pain and fatigue is not a part of aging. It's a part of their, presentation of depression or anxiety. Again, some information about suicide in older adults. Men aged 85 years and older have a suicide rate of 45.23 to 100,000 compared to an overall rate of 11 to 100,000 for all ages. So despite older adults making up only 12% of the United States population, they account for 18% of all deaths by suicide. And so that's really disproportionate and should be opening our eyes to how serious this is. And 75% of those who die by suicide, again, visited their primary care provider within the month of that suicide. So 38% visited them the week prior, 75% had visited their primary care within that month prior. Some signs to look for if you are a clinician or if you are a family member, if you have a loved one, or if you're a caregiver for an older adult. It's sadness. It's lasting for longer than 2 weeks. Consistent worries about money, family, health, consistent trouble sleeping or concentrating, having more than 1 alcoholic drink a day, or taking more medication than prescribed, an increase in risky behaviors. suicidal thoughts or actions? Are they verbalizing thoughts of suicide? Are we listening? Neglecting personal care. Are they skipping meals, forgetting to take meds, neglecting personal hygiene? Are their activities of daily living starting to decline? And an overall feeling of hopelessness and lack of purpose. Some unique needs when it comes to the older adult population. So due to age-related changes in functioning of the liver and kidneys and brain, older adults can only tolerate a lower dose of most medications and are at a greater risk for developing a number of side effects when it comes to utilizing multiple combinations of medications together. And typical psychosocial treatments, they need to be modified as they're less likely to be living with family members. So common therapeutic modalities are really aimed at individuals who are still in the workforce, who still have family maybe living at home, who still have, a pretty active social life outside of their work and home. And so these individuals, the older adults, are facing the dual stigma of mental health and aging. There's a severe shortage of workforce trained to provide necessary mental health care for a growing number of older adults. And when we talk about, and I'll go into this in a moment, think about if you're starting a medication for somebody who is an older adult and they can only handle a smaller amount of that medication, or you have to titrate slower. So their progress and their treatment is going to look completely different than it would for somebody in a different age range. So for that reason, it's really, important that we have geriatric psychiatrists who are able to inform those decision-making choices with our older adult population. However, it's unfortunate, and we'll talk about this nationally, there's 2.6 geriatric psychiatrists practice nearly 100,000 state population for age 65 and older. And I know that this image is a little small, but it talks about the highest and lowest counts of geriatric psychiatrists by state. And you can see, I think I heard someone, in Florida, we've got 79 specialized geriatric psychiatrists. New York has the highest at 218. There's several. Mississippi and North Dakota have 0. And it's kind of interesting when you know that there's a huge gap between availability and demand when it comes to our geriatricians. However, they report the highest job satisfaction among physicians. But there are a couple of things that go into this, and we're going to talk to a little bit about this when we get into talking about parity. But psychiatry, specific geriatric psychiatry, is starting to lose providers because your cardiology, your other medication, your other specialties that are guaranteed insurance reimbursements for the work that they're doing are more appealing to our younger and new psychiatrists versus doctors versus going into psychiatry, where there's a lot of insecurity as to what is covered, what is not covered. And even going into psychiatry, geri-psychiatry is one of the least sought after specialties. So currently there are about 1,700 board certified geriatric psychiatrists in the United States. So that means there's one for every 23,000 older Americans. The ratio is estimated to diminish to one geriatric psychiatrist for every 27,000 individuals 65 and older by 2030. 2030. It blows me away because that's really close. One of the specialties, the Geriatric Psychiatry Fellowship, they have training slots nationwide. There's about 125 to 150 fellowship slots for these potential providers. And at any given time, less than half of them are ever filled. So not to mention just geriatric psychiatrists in general. There's a shortage for. So Massachusetts, and I know we heard somebody is from there. So Massachusetts, the state with the most psychiatrists per capita, has one psychiatrist for every 2,377 people. So mental health issues are not going away. One thing to consider is that, again, not talking about geriatric psychiatrists, just psychiatry in general, there's currently 28,250 psychiatrists practicing active patient care in the US. However, 59% of those psychiatrists are 55 and older. And so a large percentage of our active psychiatry population is going to be retiring or reducing their workload in the near future. So despite the fact that there's this shortage of psychiatrists and mental health coverage, it's still a silent shortage, if you will. It's not something that is being encouraged for our doctors to be going into these fields. So again, while mental health issues are not going away, our psychiatrists are. And this will only continue to exacerbate a growing gap between supply and need for increased care moving forward. We talk a little bit about barriers for treatment for mental health for older adults. We'll go into self-stigma, provider stigma, general public stigma, and of course, transportation, geographic location, burdensome out-of-pocket costs. I'll touch on the bottom three currently. So transportation, there's limited access of transportation that's needed for mental health care visits. And this really hinders our older adults' ability to access these services. So if transportation is a barrier to getting to and from treatment, then that's a problem. Older adults who live in rural areas may find it especially difficult to find mental health service providers in their area. So these geographic considerations may force some older adults to seek care out of network, which then goes into the next one. You're incurring considerable out-of-pocket costs. There's burdensome costs. Consumers 65 and over, many of them on Medicare, your out-of-pocket cost, can be upwards of $6,833, and that was in 2019. So that out-of-pocket cost is up 41% from 2009. Okay, so we're going to talk a little bit about parity, and I promise not to get on my soapbox here, but it's very hard not to. In 2021, a review of parity practices, and I don't, I can't get feedback, but hopefully everyone's pretty familiar with parity. Parity is essentially my health insurance company will cover my mental health treatment as equally important as my physical health treatment. So a review of these practices, many insurer carriers, they failed to complete analysis of service and make changes to their practices regarding parity. And this was 2 years ago. This has been, I want to say in the 90s, the conversation about parity, was up and going and saying we need to address mental health as equally important as physical health. And if 2 years ago, insurers had still not made any changes to the way they were processing claims. So mental health services are often only covered 50%, if covered at all, when, medical surgical services are often covered at 80%. So for example, a health insurance issuer may cover nutritional counseling for medical conditions like diabetes, where that same insurer will not cover a nutritional consultation for an individual who has a mental health condition like anorexia nervosa, bulimia nervosa, and binge eating disorder. Self-stigma. Stigma, of course, it prevents individuals from prevents people from self-identifying when they're experiencing difficulties, helps individuals are not going to ask for help, and it makes maintaining engagement in services really difficult. Older adults themselves often share the belief that depression is a normal part of aging, and they don't seek help because simply they don't know that they could feel better with appropriate treatment. So there's also built-in biases against mental health. A fear of being stigmatized by others creates a barrier to getting into treatment. And by not getting help, feeling that you can't get help or communicate with your peers because of that stigma around mental illness, that adds on feelings of guilt and shame and self-loathing. There was a study on older adults' beliefs about the causes of their chronic illnesses, so heart disease, cancer, diabetes, found that attributing an illness to quote unquote old age is associated with negative health outcomes. So quote, old age attributions were associated with more frequent perceived health symptoms, poor health maintenance behaviors, and a greater likelihood of mortality. The probability of death was more than doubled among those who strongly attributed illness symptoms to old age versus those who didn't. So at this point, educational opportunities, it's really important that we have opportunities for seniors and older adults to be speaking to other seniors and other older adults. It's important that this information and about distinctions between normal aging and the onset of mental health is coming from their own peer group. We can talk a little bit about provider stigma. There's a research, and it is published, it's in the National Library of Medicine, found that physicians are less interested in treating older adults with suicidal tendencies than treating younger people with the same identical problems. The physicians tend to be less patient, less respectful, less involved, and less optimistic with older patients. They found nurses, this is well, I'll bring back to the nurses, we'll stay within this study. The social workers spend less time in meetings with older oncology patients than they do with younger patients. And they also found that social work students, there was a study conducted among social work students in 2004 that revealed participants' perceptions of a biopsychosocial assessment and intervention related to illness, aging, and death were affected by the patient's age. So there's stigma against aging and resulting in discriminatory behaviors towards older adults with mental illness. And this is a serious concern in the mental health workforce. And we're seeing this bias in students and in individuals who are currently working in the field. And a study was conducted in the Netherlands in regard to nurses, and they found that the correlation between the nurses' attitudes toward older patients and the quality of communication and care provided to them was affected. So the more negative the nurses' attitudes, the shorter, more superficial, more task-oriented their conversations with older patients were. Nurses tended to speak to older patients in a patronizing tone and did not involve them in consultations or decisions. So providers who call patients by their first name, which is practice, this is generally disrespectful unless it's by that patient's request. And if you come across a provider who is calling a client or a patient, especially an older adult, anybody really, cute, honey, sweetie, that absolutely has to stop. And there's the infantizing of the older adult population that is very disrespectful and stigmatizing. So to ensure competent care, healthcare providers must understand that many health problems in older adults are preventable and or treatable, and not just an irreversible consequence of old aging. Providers need to adopt a recovery-based service approach and have that optimism of recovery. So the balance between vulnerability and resilience is central to mental health promotion in certain groups with specific burdens, such as older adults who will face a higher risk of poor mental health outcomes if not being mindful when interacting with them. So we can talk a little bit about the general public stigma as well. 82% of older adults, 50 to 80, report experiencing some form of ageism in their everyday lives. So stereotype depictions present older people as frail, lonely, isolated, incompetent, and this feeds into self-stigma. An analysis of popular films from 2010 to 2020 suggests that on-screen ageism persists, and it's particularly evident among on-screen women aged 50 and older. And again, discrimination often starts with a lack of self-awareness about personal attitudes and behaviors. So if we've never taken the time to really think about how we're perceiving our older adult population, maybe we're contributing to it. Social media campaigns and education are definitely needed to increase awareness of stigmatizing attitudes around ageism and to decrease a societal bias towards older people with mental health issues. Consider this. Take note the next time that you are shopping for a greeting card and just look at the amount of stereotyped caricatures of older adults on greeting cards. Again, ageism in media. During COVID-19, during the pandemic, the stigmatization of older persons increased in traditional and social media. So news accounts, social media posting, this messaging that conveys that the discussions that we're having about the virus and healthcare and rationing really devalue older adults' lives and essentially tell them that their lives are unworthy or it's a reasonable sacrifice. So the exposure of older individuals to these negative age stereotype messaging interventions led to significantly worse mental health outcomes for our older adults following the the communications and conversations and almost nonstop conversations about masks and mandates and vaccines. And we know that older adults are 7 times more likely to be portrayed negatively than those under 50 in online ads. TV commercials, typically when you see older adults in TV commercials, it is for a medication or it's for a healthcare related service. So again, that leads to the impression that older adults are in poor health and plagued by just a host of concerns. And historically, movies, television shows, they cast older actors in the role of people who are sick or burdensome rather than vigorous and successful. Images of adults 50 plus are portrayed in a positive light 72% of the time, which is much less than people ages 49 and younger who are featured in a positive light 96% of the time. So there's a lack of media attention, particularly positive stories featuring older adults. And what we see contributes to our mental health, right? Harvard Medical School study, they found that either viewing positive or negative image of aging had a significant effect on an older adult's ability to walk. So older adults who were shown positive images actually walked faster, appeared sprier, stood up straighter, while older individuals who were shown negative images walked more slowly and more hunched over. So these things that are coming from our media and from our news outlets are affecting our mental health and specifically negatively affecting the older adult population. So these studies really demonstrate the need for media messaging aimed at empowering older adults. So ageism and media. Oops, I think we just went over that. So I'm not sure if you're familiar with this gentleman here. He is the most interesting man in the world. And this was really one of the ad campaigns, and I think it was for Heineken, that was really revolutionary. They decided specifically to find an older individual and have him be active and social and likable and enjoyable. And this campaign ran for a long time. And it was kind of one of the first times that we saw a change in the way that older adults are being perceived in our media. So there was a study, ARP teamed up with Getty Images, the stock media supplier, to introduce a collection of 1,400 images in 2019. And what they found was that based on a random sample of over 1,000 images published or posted by popular brands or groups, less than 5% showed older generations handling technology, even though Pew Research has shows that 69% of people between 55 and 73 own a smartphone, but yet less than 5% are being portrayed like that in our media. When you do a image search, ARP found that only 13% of images reviewed showed older people working. Yeah, more than 53 million people older than 50 are employed. They make up a third of our labor and our workforce. So Getty Images, they identified that what we need is imagery showing mature adults leading full lives. And you can go online and just Google older adult, and it's great. They've really taken some significant steps, and they added 14,000 images in 2019, and it is older adults living full, vibrant lives to help change that stigma and change that narrative. So when it comes to improving mental health outcomes, good mental health requires that the social determinants of health are present. So that is affordable and appropriate housing, adequate income, education, social networks, transportation, all of the same social determinants of health for anybody else still need to be present for successful, positive mental health and well-being in our older adult population. So for mental health providers, the balance, again, between vulnerability and resilience is a central concept for improving mental health outcomes for older adults. Group cognitive behavioral therapy, interpersonal psychotherapy, and group life review or reminiscence therapy are a couple of really great ones for working with older adults. For those of you who are prescription and are able to write prescriptions and medication providers, if considering medication for older adults with depression, the APA recommends combining it with interpersonal psychotherapy. And I think we know, and being a clinician myself, that it's both. It can't be one or the other all the time. And I think the APA is saying, yes, please encourage psychotherapy, and specifically group therapy is fantastic for the older adult population because you get that social connectedness. There are some advancements in healthcare, so it's pretty exciting. We know telepsychiatry is really common now. Telehealth visits are, nationwide, worldwide. Telepsychiatry is well recognized, and it's established a method for providing mental health care, and it's in use in all areas in the United States and many countries. And the American Psychiatric Association fully endorses video conferencing as an effective means of psychiatric health care delivery. So if these are individuals in rural towns and rural areas who don't have that transportation, there's no reason we shouldn't be looking into telepsychiatry. Again, that ties back into our insurers. We need to be advocating and making sure that our insurers are going to cover telepsychiatry. Most of them still do, but some of them don't. And studies have shown that telepsychiatry can be as effective as face-to-face for depressive disorders, substance use disorders, bipolar psychiatric disorders, and anxiety disorders, which we know are most common in our older adult population. So virtual reality, there are a lot of really cool things happening with virtual reality in clinical settings with adolescents and children, but there's a lot less being studied in the geriatric population. However, there is some study by Kent University out of the United Kingdom found that exposing our older adult population who have dementia to virtual reality experiences gave them back old memories. It reduced aggression, improved their interactions with their caregivers, and other research findings demonstrate particular promise for addressing mental health issues as they highlight pathways through which immersive VR may really be able to enact a lasting psychological impact and behavioral change. However, VR lacks consideration for age-related changes such as visual acuity and hearing, because of much of the research on VR development was on, fully abled visual and hearing individuals. Integrating speech recognition tools can provide really insightful tools for social and emotional functioning. There's smart home sensors, there's wearable devices. There are a lot of technology that is coming out that could be really helpful for our older adult population when it comes to managing and maintaining awareness of their mental health and their status. It just needs to be really mindful that it has to be efficient and clearly beneficial to its users. So it really needs to be developed and presented in a way that it's easy for our older adult population to use. Otherwise, what's the point? So tips on aging. It's important to develop a positive attitude about aging. In fact, when you do, researchers say it can add almost 8 years to your life. Social support. So adequate social support. We know that peer support programs are beneficial to the services and both to the users and benefit the peer support workers. So peer support can look like helping individuals, in a variety of different ways. It can be emotional support, informational support, instrumental support. So that would be, sharing problems or venting, or advice and guidance, or providing tangible rides or assistance with housekeeping. So all of these things can be really beneficial to increasing that connectedness. So increase social connectedness. Some of the things that we encourage is opposite action or behavioral activation. It's a DBT skill, and essentially is saying, just do it, right? So you feel like staying in bed, you do the opposite action. You go outside. You feel like not eating, you do the opposite action. You have a snack. You feel like isolating, you do the opposite action. That behavioral activation, you call a friend or a loved one. So those type of tips and things can come out through group therapy. There are a couple of resources as well here that I have. There's senior groups, there's Senior Core, there's Engaged, and these are other resources that connect older adults across a variety of communities. Finding purpose and meaning, focusing on what you can do and not what you struggle with. So it's about perception. Volunteering for an organization that supports a cause that you care about. I don't know if you're familiar with the Gray Panthers, but there's a series of multi-generational local advocacy networks across the United States, and they confront ageism and many other social justice issues. And this organization was formed by Maggie Kuhn, who, in response to a forced retirement by the Presbyterian Church, she was 65, and this was in 1970. She was forced to retire at age 65, strictly based on ageism. So she created the Gray Panthers. So if there's something that your clients, your family, yourself, you're interested in, volunteering for that organization or creating that organization can really help you regain and find that purpose. Travel, even if it's spending time outside walking or going to a beach or just spending time in your own green space. And exploring your hobbies. Retirement's the perfect time for seniors to dust off that bucket list and pursue lifelong goals, gardening, sewing, painting, whatever it might be. Incorporating healthy habits, and this is nothing new, moving your body, staying active, being mindful of what you're eating, practicing good sleep hygiene. It doesn't have to be extensive exercise or, you don't need a ton of gear, just moving around, getting outside of the house, walking, maybe if you can, up and down the street. Anything that gets you moving is really helpful. So small ways to add it up throughout the day. So maybe park further from the store or take the stairs or light housework or gardening. It all adds up. So just staying active and getting enough exercise is really important for our older adults. And diet can impact symptoms of depression. So the quality of protein, complex carbs, healthy fats, they leave you feeling satisfied and emotionally balanced. So if we go too long without eating, it can worsen your mood, make you tired and irritable. So maybe that's setting a reminder on your phone or an alarm on your watch that helps remind you to eat at particular times, keeping really healthy snacks with you in your bag. And sleep, you want to aim for anywhere from 7 to 9 hours of sleep a night. Better quality sleep is, if you avoid alcohol and caffeine, keeping a regular schedule, a regular sleep and wake schedule can be beneficial, and making sure your bedroom is dark and quiet and cool can all be really helpful when you're looking to improve your sleep hygiene. So mental stimulation, brain games, just as the body needs physical activity and stimulation to stay healthy, the brain needs stimulation as well, just to stay sharp and avoid cognitive decline. So any activity that keeps the mind engaged, and that can be, of course, whatever you're interested in. And screen time, I found this one particularly interesting to mention screen time as something that is actually pretty important for our older adults. It really alleviates effects of senior isolation. However, it should not be used as a replacement for in-person social interaction. In-person social interaction is by far better than having as we know, these Zoom calls that go on or, a FaceTime call in person is always best if possible. New studies have found that older adults using social media acquire positive instances related to their personal and social life, and they feel more engaged, they're in constructive activities, and they focus on self-education and love, where social media to connect and learn, not going to Facebook and Instagram to compare oneself to another. So it's really important that caveat is mentioned there. So the University of Missouri did a research study, and they found that social media use triggered depression only in people who use various sites like Facebook, comparing themselves to other. Where our older adult population is typically using social media to connect with other people, to research recipes, to look into hobbies. And so it's a benefit to be able to have your phone and use it. Pet companions, where appropriate, animals can help keep owners active, offer companionship. And according to the CDC, many studies show that the bond between humans and their pets can increase fitness, lower stress, and bring happiness. They can decrease blood pressure, decrease feelings of loneliness and isolation. And it also increases your opportunities for socialization if you're out and about and you're taking your dog to the park, those type of things. If you don't want or aren't able to own a pet, volunteering at an animal shelter is a great way to connect with animals and help an organization that's in need. And tips for helping loved ones, invite your loved one out, make that call. Don't assume that they're going to call you. You've got to really take that proactive role. Do active things together that they enjoy. So at this point, it's not about you. So you got to put that aside and understand that you're wanting to help their mental health. And so maybe that means doing something that they enjoy that maybe you don't care about so much. Scheduling regular social activities as much as you can make it routine. That'll be really helpful. Plan and ensure that they have plenty of healthy food available. Make sure you're checking on individuals who you care for. Make sure their fridge is stocked, that they have what they need, and that what they have is going to be healthy and really beneficial for their body. And if you're concerned about a loved one, offer to go with him or her to see the healthcare provider for an evaluation and treatment. Be that social support. Have a conversation about it, talk about behavioral health and mental health, and, bring up the conversation. Are you thinking about suicide? It's just that important that we engage and have this conversation with our older adult population. So I'm going to close out with a couple of resources, and these are, nationwide: the Administration on Aging, Behavioral Health Treatment Services Locator, Health and Aging, mentalhealth.gov, tons of resources here. And of course, the Senior Living Guide has, extensive directory on retirement communities, resources, ebooks, healthcare directory referrals. And so in summary, I just want to wrap it up. Anxiety and depression are not a normal part of aging, although it can be common. Public campaigns and social media contribute to stigma and ageism, and we need to be aware of it. And I want to leave you with this quote by Maggie Kuhn. She is the founder of the Grey Panther movement. There are 6 myths about old age. 1, that it's a disease, a disaster. 2, that we are mindless. 3, that we are sexless. 4, that we are useless. 5, that we are powerless. And 6, that we are all alike. Well, thank you all so much for your time today. And we have got a little bit of time left if there's any questions.
Wow, I love that. That was absolutely amazing. I love that last slide as well. So I'm going to use that somewhere. I'm going to tell you. So this is my little feedback before we get started, because we do have some Q&A, but this has probably been a webinar that we've had the most comments that have been incredible comments. And as far as just feedback during the webinar, that I think I've ever had, to be honest with you. So I'm just going to go, it's not as much question, but just relatable. Let's see here. There was just a lot going on during your webinar. See, I got to scooch back here a little bit. One was, where did you find your stats? Is there a place where you found those that you can share?
Absolutely. On my next slide are my citations, and I'm assuming we can send out this
That sheet,
the sheet or the slide deck if you'd like. But a lot of them came from the CDC, the World Health Organization. Gosh, let me see if I can just read it. A lot of them were clinical research studies, the APA, Becker's Health Hospital, and I'm happy to share this slide with you.
Yeah, we'll just go ahead and share that. So there was the comments, the lack of parity is concerning. They're just conditioned to go it alone. And I think that's absolutely true. I think that, they've powered through this their life. They're strong, independent people. And I think that is absolutely true. They don't want to be a burden. I think that's what a lot of it is.
Mm-hmm.
And then sometimes the comment, the doctor's not asking the right questions. I agree with that as well. Because I think sometimes there's especially with seniors, they have a lot of medical issues. They have a lot of things going on. So it's a lot of time that you really need to allot for a senior to go over the physical stuff, and they're not really hitting the stuff beyond the physical. So I agree with that. And that was, I think, that comment there. So, I mean, a lot of this is so eye-opening, Amanda, because this stuff you don't really even think about. Yes, and then the other comment was the doctors don't take the time, so the person goes untreated. And then the comment from Evelyn was, I hate the term senior moment. And we use that so flippant, right? And then someone who's a social services director at a skilled nursing facility, mostly long-term with short-term. It's hard to find a psychiatrist, it's hard to find psychiatric and counseling services for some of the residents. The company they currently use either cancels or is just there for a small amount of time. And that was prior to you mentioning the telehealth. So that's clearly a great solution that you pulled in there after mentioning that. So hopefully that's something that the company that they work for can maybe look into as an option. And then there was a comment that they have another assisted living memory care, so they have the same issues. So there's just so much, engagement. I thought it was really great. And then there was the comment from Chet that the psychiatric telehealth is working well with their program. So they're having good success with that. And then Jacqueline mentioned, sometimes it's very challenging encouraging elderly skilled nursing facility residents who have little family involvement to find meaning and purpose. A great activity program is essential in this population. So that feedback, and very difficult and unique challenges for the veteran population as well.
Absolutely.
Military men, who remain very self-determined, and sometimes men can be very stubborn. So yes, for sure.
And that added layer of stigma when it comes to mental health, but now mental health on somebody who was a service member,
Yes.
It even reduces the likelihood that they'll talk about it.
Yes, 100%. And then some feedback, someone works in the service division of local government. They do an amazing job of offering a variety of activities in the senior centers. So social interaction is very important for mental health and outlook. 100, anytime you have social interaction, I think that is a huge key. And I think you start taking that social interaction out of really anyone's life, but especially a senior, it is a game changer. And I think that's probably why you saw so much depression increase significantly over COVID. I think it really affected our senior population more than anyone's really discussed openly. Oh my gosh, the next comment, I didn't even see this, was our population really suffered during COVID when there were restrictions on group dining, because they thrive on interaction during meals specifically. Everybody wants to chat during meals because you're talking about the food, right?
Right. We're social beings. We want to be and connect with one another.
100%. Let's see here. There's just so many great comments on here. One of them I'm going to just tell, I have enjoyed this webinar, so informative and heartfelt, especially it takes an attempt to get people that initial mental health support. So that's a nice comment. Oh my gosh, there's so many comments. One is, do you have any senior training classes on the computer?
I do not, but there may be.
Actually, not a bad idea.
Yeah.
Yeah. And one is there an overlap between dementia and depression? And there clearly is.
Yeah, I think, it's difficult when you start talking about dementia because that is, the physical brain changes, whereas depression is more of the chemical changes and instability and imbalance. But surely, I don't know that. That's not my area of expertise when it comes to, dementia. I can't speak to that, but I can assume that there probably is.
So we have someone on here, Carol, who is 83. So congratulations on that, Carol. And she says they are all myths.
I love it.
So, And then another good comment about how great the webinar was. So that's really great. And then I do know that there was some Q&A in here. So I'm going to cover these really quick because I know we're really tight on time. I think you answered this one here about unlock the mental health, why it's not normal. Have you seen any increase in clandestine hemlock societies, particularly in CCRCs? I don't know what that means. I don't know if you do.
I do not.
Okay. So that was from Makaira. I'm not sure if I pronounced that correctly. But Makaira, if you're still on, please go ahead and email back that same question, and I guess we'll check into what that means, or if you can just clarify that in an email, because we do have to jump on because we're hitting at that hard 3 o'clock, and I know that Amanda has another engagement as well. But please know that I will be sending this out with my email and the link to the video for this as well, and Amanda's information. So if you missed anything or you would like to connect with her directly, all that will be in that follow-up email. And I think that is about it. Thank you so much. We really enjoyed having you all on our webinar today and look forward to another webinar with everyone. Thank you so much, Amanda.
Perfect. Thank you. Bye-bye.
Thank you so much. Everyone have a great day.